So, does does a guideline panel only make strong recommendations when they have high confidence or high quality evidence, or are there other factors?
Well, one thing to consider is that the recommendation that the guideline makes is an opinion, it's a judgment. And sometimes we are faced with the notion that expert opinion is a form of low quality evidence, and that's not true. We separate clearly the evidence, which is a result of research, from opinion, which is the judgments that are made based on something, hopefully based on the research, as well as the personal experience, consideration of the relevant values and preferences, and understanding of the context in which the recommendation will be applied. So expert opinion is what will result from the work of a task force after they consider the relevant issues. So the recommendation, that opinion, that judgment can lead to a strong recommendation, which has the implication to the user that they just have to follow that they just have to do it, and then as a result of just doing it, the patients will be better off. That we don't have to consider that carefully the context in which the recommendation will be applied, or the distribution of values and preferences that may exist among patients who are subject to this recommendation, that given the most common circumstances, the majority of people will agree that that's the right course of action. And you can make that strong recommendation in favor of the intervention, or you can make a strong recommendation against pursuing the intervention. You can also make a weak or conditional recommendation in favor of pursuing the intervention, or weak or conditional recommendation against pursuing the intervention. And your question had to do with whether one is marrying the quality of evidence with the strength of recommendation, and whether one has to make a strong recommendation only in the presence of high quality evidence. While that is the most common circumstance in which one can make a strong recommendation, that is when one is quite confident about the estimates of effect, the circumstances in when one makes a strong recommendation there require that the benefits greatly outweigh the harms and costs, that the relevant preferences are fairly uniform in the population of interest, and that the intervention is affordable within the constraints of resources in which healthcare operates. There are other factors, but those are the key ones. For a strong recommendation to be made in the context of weak evidence, usually this happens when there are no other alternatives of action, alternative course of action, and the weak evidence relates in ways that can be easily overcome by considerations of context or values and preferences. Let me share some examples. Whole body CT scanning is a procedure that may perhaps yield some unexpected finding, often yields incidental findings of unclear or low importance. It is costly and incurs additional costs for workup, and exposes patients to radiation. Thus, there is low quality evidence supporting the benefit of whole body CT scanning. And in that context, task forces who prefer to avoid harms and costs on patients, even if foregoing potential small benefits, may make a strong recommendation against whole body CT scanning. A task force that wants to make a strong recommendation in favor of whole body CT scanning in the context of the evidence I just described will have to make a very strong case for why they would prefer to obtain the potential benefits of early detection of some abnormality, and how that overcomes the undesirable effects of burden in terms of cost and the radiation burden to the patients. Another example could be in children who have fever, and one may want to consider using aspirin or acetaminophen. Aspirin has been linked by low quality evidence, essentially by case reports, to Reye's syndrome, which is a pretty significant health condition that occurs in children. This Reye's syndrome can lead to death. Using aspirin in this context, while only linked by low quality evidence to Reye's syndrome, is strongly recommended against in children, because there exists a perfectly fine alternative, in this case acetaminophen, that has not been linked to this condition. And as a result, it would be foolish to try something that could be potentially harmful and fatal when a safe alternative of low cost exists. In that case, a task force, even though the evidence is of low quality, linking aspirin with Reye syndrome may make a strong recommendation against aspirin use and for acetaminophen use. So here are a couple of examples where there's low quality evidence of high risk of bias, in which the task forces can make strong recommendation against, in one case, a diagnostic test, in the second case, against a treatment.
Can you also give us an example of the opposite, when you have a high quality evidence, but yet you can issue or develop a conditional or weak recommendation?
The most common circumstance where you have strong evidence, say from multiple randomized controlled trials that provide precise and consistent information that bears directly on the issue, where you still don't provide a strong recommendation, is when say an intervention yields important benefits but causes important harms, such that the balance, how desirable it is to experience the benefits and how undesirable it is to experience the harms that comes with the treatment, that balance becomes problematic, it becomes very close. And so patients may want to have a strong voice in that conversation, as some patients may prefer to avoid the harms and still be quite reasonable, and other patients, equally reasonable, may prefer to expose themselves to the harms by pursuing the important benefits. An example will be the use of an anticoagulant such as warfarin for the prevention of stroke in older patients who have a history of gastrointestinal bleeding. In that case, independent patients may place a very high value in avoiding a disabling stroke, even at the expense of experiencing a recurrent gastrointestinal bleed because they took the anticoagulant. Equally reasonable folks may prefer to run the risk of stroke, but prefer perhaps to avoid gastrointestinal bleeding and the hospitalization and cost associated with this. And one can easily imagine patients in their own practice where they would have preferences in those two opposite sides. To that extent, one could make a weak recommendation in that circumstance in favor or against warfarin in patients with a history of gastrointestinal bleeding. One can also easily imagine patients at very low risk of stroke and also very low risk of bleeding, who may find it attractive to prevent stroke and unattractive to increase the risk of bleeding, but again, because those risks are both quite low, may find the treatment may not be that sure as to what would be the right course of action. In that case, again, the task force may make a conditional recommendation and invite patients and clinicians to engage in shared decision-making to decide what is the best course of action for this patient at this time. So again, an example of high-quality evidence at very low risk of bias, yielding only weak or conditional recommendations.